Good evening, everyone, and welcome. It's so good to welcome colleagues and friends from across the world, really, to tonight. So my name is Professor Daniel Kelly, and I'm currently the convener of the Royal College of Nursing Fellows. And just to tell you a little bit about the Fellows, if you don't happen to know, the Royal College of Nursing has awarded fellowships since 1976. So we have a large number on the Roll of Honour. Some of whom, of course, since that time are no longer with us, but many are active, and each year we appoint new fellows. So it's a wonderful honour, and I work with some wonderful colleagues who are fellows and who come from a whole range of areas of nursing, healthcare, and well-being, indeed. So it's a really good mixture of expertise. And during the COVID pandemic, we began this process of allowing some of those experts to join events that we called Conversations with Nursing Pioneers. And each of those events have taken a slightly different focus, but they all have three fellows invited to meet with a distinguished chair. And the evening then is shaped around a particular theme. Tonight it's around global nature of nursing and the future of global nursing. Past events have been recorded. This evening's will also be recorded and made available on the Fellows webpage. So if you do wish to access either tonight's recording again or a future past recording, you can go to the webpage and access previous recordings there. This is the 6th in the series, so there's quite a few to be able to see. And each year we do 2 of these events. The next one will be, we hope, coming from Scotland. So this evening's is based from the RCN in London, but the next event we're hoping will be streamed from the Scottish headquarters in the capital of Edinburgh. So that probably will be in September time. So watch out for the next in the series of Nursing Pioneers. Just to say a few words about housekeeping this evening. I know most of you will be very aware of Zoom and how it works, but please, when we're conducting the conversations, please stay on mute, because that helps us to remove any background noise. And also, if you do have any questions, comments, or thoughts, please do feel free to share those with us. And we'd ask you to use the chat function to do that. It's probably the easiest way to either pose a question or indeed just a comment. So please do feel free to use the chat during this evening. The fellows, just to say, the distinguished fellows we have this evening, I will leave to our chair to introduce. But the fellows in the Royal College of Nursing come from a wide range of backgrounds, practice, policy work, leadership roles, education, and indeed research. So they do cover the wide range of interests, and therefore their expertise is quite unique. And I feel that we have much to learn from this group, and this is why we organize events such as this. So please do take a look at the website, take a look at the web page for the RCN Fellows. You will find blogs on there from each of us. We write a monthly blog. You'll find the recordings. You'll also find biographies of current and past fellows, also uploaded by the RCN Library, who also help us with these events. So a big thank you to them. So without further ado, I'm going to pass over to our very distinguished chair this evening, and we're very honoured to welcome Dr. Amelia, Latu, Afuhaamango, Tuipulotu to host this evening's event. So Dr. Amelia, welcome, and thank you for being our chair.
Thank you very much, Professor Daniel Kelly. And it is such an honor to be here with all of you, and such an honor to be with our distinguished panelists. I am very happy to be able to speak with you this evening and introduce myself. I started nursing in Tonga, 21 years old, and I was put straight to be in charge of the busiest ward in our tertiary hospital, the surgical ward. From there, I went on after 1 year and become in charge of the psychiatric ward. Then I continued to be a lecturer at the School of Nursing, becoming acting principal of the School of Nursing, and later became director of nursing and chief nursing officer for Tonga. I did my education in Australia, my bachelor, master's, and PhD. And I want to share that together with our very talented visionary nursing midwifery leaders of Tonga, who have supported and guided me throughout my journey through the tough and challenging times of leading at a young age, navigating a very tough health system in order to influence financial budget allocation and to influence policy decision-making. Very happy for our nursing pioneers in Tonga, but also for all the nurses of Tonga and midwives. Together, we move on a lot of fronts, key fronts in Tonga regarding strategic directions and planning for Tonga, implementing key activities for development and improvement for Tonga, which includes development of our national professional standards for the registered nurse and midwives, our code of ethics and conduct, policy and procedure manual, and very lastly, before I left Tonga, was the Nurse Practitioners and Midwives Act that I presented in Parliament and in Cabinet and approved and given royal assent. So for me, that is a huge milestone, the ever first time nurse practitioners and midwives is mandated by law. I want to also emphasize the importance of strategic planning and, of course, high-level planning to go together with an implementation plan of activities, but most importantly, the need that there is budget allocation, sustainable and predictable budget allocation to finance and to deliver the activities that are planned for nursing and midwifery. I just want lastly to share that from WHO, my vision is to be a trusted global leader to strengthen nursing and midwifery, to maximally transform health systems, to serve the most vulnerable and the communities. And mission is around strengthening future health systems towards universal health coverage and the sustainable development goals, and to assist raising the profile for nursing and midwifery, advocating for investments, ensuring that their competencies and skills and knowledge are well utilized within health systems and to ensure that they are protected, supported, valued, and respected. So that is from the global stage and my work here in WHO. But tonight, we are delighted to hear from 3 distinguished pioneers of the Royal College of Nursing Fellows who have done huge work within the United Kingdom and also around the world. First is Professor Dame Anne-Marie Rafferty, CBE, and Professor Dame Anne-Marie Rafferty is Professor of Nursing Policy and former Dean of the Florence Nightingale Faculty of Nursing and Midwifery and Palliative Care at King's College, London. Dr. Barbara Stilwell is former head of the Global Advocacy Campaign for the Nursing Now and is now a consultant on a global project on nurse leadership. And our final distinguished fellow is Professor Helen Allan, who is a professor of nursing at Middlesex University, London, United Kingdom. Now I will hand over to our very distinguished fellows to introduce themselves, please. Dr. Barbara Stilwell, please, the floor is yours.
Thank you, Dr. Amelia. It's lovely to be here with all of you. And thank you so much for inviting me to take part in this. I feel in some ways I've, as you do often at my age, I've come full circle because I started my international career with WHO. And here I am with the great honor of having Dr. Amelia here, with both of us with a big interest in health systems, I think. And that was the way my career developed. So I've been asked to say a few things just about how my career developed and got started, because I hope it will encourage all of you. I was working at the RCN, and I was working on introducing the nurse practitioner role, which is why I was awarded a fellowship many years ago. And while I was doing that, I was asked by somebody else who was a fellow, Jane Salvage, if I would assist in a project that was being run by WHO, but supported by a number of nursing organizations, to reintroduce nursing and to strengthen it in some of the countries that before 1990 had been Soviet Union countries. And the project was irresistibly called LEMON, Learning Materials on Nursing, which I thought was the most genius name ever, because we could hold lemonade to raise money for it, which we never actually did, but it kept us going. We had lemons all over everywhere. It was my first introduction to sharing expertise and materials that many nurses from the UK, from many different places, shared with us, and the publishers gave us the copyright to be able to share them with nurses in all of these different countries. So from Latvia to Kazakhstan, we went with our nursing lemon materials and our lemons, and spoke to so many wonderful nurses and discovered so much about the value of nursing, you know, particularly when it's missing. So that was how I initially started. And having done that work, a role came up in the immunization department at the World Health Organization in Geneva, where Dr. Amelia is. And they needed somebody to sort of step in and take up a training role, which had been unexpectedly left vacant. And the RCN seconded me for 6 weeks. I went for 6 weeks and I stayed for 10 years. And that is the cards you're dealt, isn't it, sometimes? And I have to say, I've had a wonderful career in terms of the people I've met, the things I've been able to do. I just, honestly, there is nothing like meeting people from around the world to really open your eyes and, you know, to know what's going on. So I moved from immunisation after 6 weeks, but not back to the RCN, but over to health system strengthening, which I then stayed in for 9.5 years. And I had a focus on migration of health workers for a while, which again was, you know, hugely eye-opening about what we came to call the carousel of migration. I learned to be a negotiator. WHO kindly supported me to do that. It's been a wonderful skill to have. And I was then recruited to be a workforce specialist in the USA. My son used to say, are you sure they like you, Mum? Because they sent me to, in this order, South Sudan, Palestine and Afghanistan. And I lived in all of those places, and I became a specialist in fragile states and workforce development in fragile states, which as a consultant I still do. So I've lately been working on the Libyan health system with nurses there. So you can see it's a lifelong passion that brings me here. And I would encourage any of you, if you have this opportunity, really, it's an opportunity to take. Thanks, Amelia.
Wow, amazing work that you have done, Dr. Barbara. Thank you very much. And we'll move on to Professor Anne-Marie Rafferty. The floor is yours.
Thank you, Dr. Amelia. Well, my kind of foray into the international world, and I can see that my colleague, Professor Michael Traynor, is here as well. We were colleagues at the London School of Hygiene and Tropical Medicine, actually started, I think, with a stint in a project which was funded by the World Bank on the, again, very much like Barbara, the emergent countries in transition from Central and Eastern Europe, were at that point exiting slowly from communism, or maybe not so slowly, suddenly, with different types of political changes, some, you know, soft revolutions. And I went to Romania to help with some capacity building in public health, and that was incredible as well. It was a mainly educational development type program. And I suppose most of what I've been involved in has been in Europe, and probably at the higher end of the economic gradient. But I mean, all European projects include a mixed economy, I think, of countries. So there was some continuity with that in the research that we did in an international hospital outcomes study that was basically led by Linda Aitken, who was also my mentor for, again, a Harkness Fellowship. I was fortunate enough to gain a Harkness Fellowship in health policy, and I'd love if more nurses were to apply for these very prestigious fellowships. They're highly competitive, but it would be brilliant to see more nurse candidates applying there, because they give you an opportunity to spend a year in the US working at some of the top health policy think tanks and universities. And it was a formative and generative experience for me. And Linda has been a lifelong mentor, and really, you know, I owe most of my career to Linda Aitken, it would have to be said. And the leadership that she has shown in health services research and these huge studies that we've done demonstrating the impact of nurse staffing on patient outcomes, including, you know, when care is under-delivered or when staffing is poorer. the rationing impacts and the costs and the consequences of poorer care. So that's taken up quite a lot of my time and energy over the years. And, you know, because before I met Linda, I was I was really a historian. So she always says that she converted me to health services research. So there we are. And it's been absolutely brilliant. But I have had the privilege of also working, you know, with WHO, like Barbara, funnily enough, through Jane Salvage, again, helping with the chief nursing officer meetings, and also spending some time as a visiting professor, collaborating with colleagues at the European Observatory and WHO collaborating centres in Berlin and in Brussels, and more recently in Leuven with the Human Resources group there. And I was lead author of a book on the role of nursing in strengthening health systems. There's something that resonates again with WHO. And that was a case country study and analysis, and that was published in 2019. And there's a follow-up volume, which is actually plays to some of the themes that we're going to be talking about tonight. And, you know, in addition to that, I've been involved in work with ICN and also Sigma through the GAPFON, the global analysis of nursing program, which, I mean, one plea I might make is that, you know, we keep reinventing, you know, the wheel to some extent, because each organization does produce its own vision. And I think, you know, we have to really synthesize and bring these together. And I'll talk a little bit more about that later, but I guess that's enough from me. Thanks.
Wow. Thank you very much, Professor. Again, a very distinguished career. Thank you very much for sharing. We'll move on to Professor Helen Allan, Professor of Nursing at Middlesex University, London. Thank you. Over to you. The floor is yours.
Thank you, Amelia. So I always describe my career as three careers. First as a nurse practitioner, where I ended up, not in the sense that you mean, Barbara, but I was a ward sister in ICU. And then as a teacher, and then as a researcher. And my two strands of research, for which I think I was appointed a research fellow of the Royal College of Nursing, was in reproductive health. So I'm very delighted to see Jane here, who's a colleague of many years, and in migration. And I was first approached by the RCN, by the Labour Relations Department, because they were having so many calls from distressed overseas nurses, inquiring about their situation, asking for help. And we did an exploratory study, and we published it as We Need Respect. It's on the RCN website still, it's on the Middlesex website, 2003. And a major finding we wrote about was institutionalized racism, and it was a huge shock for me. And I should go on to say something about that in a minute. There wasn't much known at the time, despite work by another nursing pioneer, Carol Baxter, who was a great, I think her work was 1970s, 1980s, into the experiences of the NHS for Black nurses. She called it the Black Nurse, an Endangered Species. And as a research team, we were overwhelmed by the overseas nurses' responses to participate in the research. And we called it We Need Respect, because that's what they demanded. They demanded we need respect. The second study we were pleased to be funded was a study, it's called the Rio study. It was a study into career progression of overseas nurses in the UK. In 2006, and things have changed hugely, but in 2006, it was very clear that overseas nurses had been recruited in huge numbers into the UK, but they were being employed, underutilised and employed in very low staff nursing grades. And so we were interested in what was going on. Of course, from our first study, we suspected it was related to institutionalised racism. And what do you know, it was. That was when I was at the University of Surrey. And then I did a third study when I was at Middlesex in 2014, where I looked at yet another facet of institutionalised racism, where overseas nurses who had difficulties in passing the IELTS, which is a language test, were employed as healthcare assistants. And in the 2 papers we published from that study, we argued that this was exploitation and another example of institutionalised racism. So all 3 deal with racism, exploitation and ethnocentric attitudes of British nurses, i.e. the way we, and I say we as British nurses, think the British nursing is best. In the latter third study, it wasn't until then that I began to reflect on white privilege and my own racialised white identity. I've published a paper on this, which is in Nursing Inquiry. And it was a profound moment for me to think back on 10 years of work where I had been a white researcher investigating the experiences of Black and other ethnic minority nurses and not really realise my role as a white researcher and a white nurse and how I'd been privileged in my entire career from my white identity. I've got a number of students who are using their doctoral studies to explore racism in different fields of nursing, and Michael Trainer, who's present in this Zoom. He and I recently published a book on racism in nursing, where we invited our students to publish their doctoral work as part of an edited collection. So unlike Barbara and Anne-Marie, I haven't operated at the strategic level. I've kind of been engrossed in all the data. But racism and investigating it and how it manifests itself and reproduces itself in different guises is what interests me, partly because of my training as a sociologist, which I did a degree in sociology after I'd been a ward sister. So I think that was what I was going to say. Thank you, Amelia.
Wow. Wow. Amazing, Professor Helen, the work that you have done and the topic of your research and extensive work. Well, I just wanted to say here before we move on to questions that, you know, if you do not mind, that I will be in contact with all of you for further dialogue with regards to the work that you do. Absolutely huge potential to support the work that I do within WHO. We'll be moving on to our questions. And the first question, I will give it first to Professor Anne, and then you can all answer you know, after Professor Anne, and then it can go to Dr. Barbara and to Professor Helen. The question is, globally, the number of registered nurses either leaving or considering leaving the profession has in recent years dramatically increased, driven in part by insufficient staffing, workload, COVID-19, and emotional toll. What would be your suggestions on how can we change this culture based on your international experience?
Well,
Professor
thank you
Anne.
very much, Dr. Amelia. That is, of course, the $1 million question. And if we knew the answer to that, then I think we would be in a much stronger position. But it's one of those wicked problems that has many different strands to it. And I mean, the simple answer is basically you need to give people the conditions that they want to work in and incentivize that appropriately. And I mean, I think this is, you know, when people are leaving the workplace, it's signaling something's not right, isn't it? Because people come in to the profession, they have got aspirations to progress, and you know, we know that there's evidence that people from ethnically minoritized communities, this is Helen's area, don't progress at the same rate as their white colleagues, certainly not in the National Health Service. So I think there's recognizing the problem, and then there's trying to do something about it. But it's really the work environment that has got the push and the pull power to really transform that experience. But if I can just say something about nurses as, if you like, nursing is an asset, and nurses as global workers. I think that nurses are very shrewd kind of judges of the quality of workplaces and their power actually to make or break the viability of those workplaces by moving, and people voting with their feet if they don't feel that they can, speak up adequately. I think that's a very powerful sign, as I mentioned, that things aren't right. But I think, there's many ways in which nursing is, the way we frame it, in terms of your area, Dr. Amelia, the Sustainable Development Goals. Nursing contributes to, I don't think there's even one of those goals that nursing doesn't contribute to. So I think it's also having a narrative that makes people, nurses and the public, actually understand what the value of nursing actually is. And I think that, we can do that in terms of demonstrating the business case for investing in nursing. I mean, clearly the State of the World's Nursing Report has got three engines in it. It's got education, investing in education, decent jobs, and in leadership. And, there's no excuse for governments not to know what to do. And, the strategic directions from WHO, I think, are very helpful in enabling us to move in that kind of way. But I think we've also got to recognize that for many, particularly nurses in lower income countries, nursing can be a passport out of poverty. And you might argue that actually, that it is a highly targeted way of actually reducing poverty in certain countries through remittances. Some people say, and we have no real hard economic evidence on this, that the combined global budgets of countries, of their aid budgets, actually is less than the global sum total of remittances from nurses. And nurses are, one of the most mobile groups of female workers. And it's very interesting in certain cases. I mean, particularly, and I was just speaking to someone from Nepal the other day, and nurses from Kerala, they want to come into nursing in the first instance because they actually send out adverts on social media for marriage, their prospects. Nursing is a passport to a good marriage, and it's an economic relationship as well. And until recently it was possible, we're clamping down on migration of people coming to the UK with their families, which some of us would believe is a big mistake. But that nurses are very shrewd economic actors. And I think their discrimination is again showing where, wards are understaffed. We know that that's, one of the major predictors of turnover and intent to leave. But I think we've got to also see participation in the nursing workforce in positive terms as a way of ensuring gender equity. It's a source of employment for women, and provides a kind of social security net for women and protection for the population, and Barbara and Helen's areas of advanced practice. And I think that's particularly the case in relation to chronic disease management, multimorbidity. This is all where, Western economies certainly are heading with negative demographics, it's going to get really, really tougher. So I think, you know, nurses are key ambassadors for, you know, Amartya Sen, who's a famous Nobel Prize winning economist, capability theories of spreading those capabilities and enabling people to, you know, exercise agency. And nurses are often portrayed as having the opposite of agency, perhaps being victims. But no, nurses are really trying to take charge of their own, sometimes quite precarious destiny in the job market. And, you know, it's a big wake-up call for employers. And there's no shortage of solutions, but investment has got to be part of that call to build a care economy, I believe. Being British, I would say a Keynesian type of care economy to secure a healthcare platform for the future, to provide health as a vehicle for economic growth. Health is wealth, and I think interventions at that level is what's needed to change policymakers and decision makers' minds and flip the view of health as a cost and not an asset. I guess that's my take. Thanks.
Thank you, Professor Anne. We'll continue with Dr. Barbara and Professor Helen.
Thanks, Dr. Amelia. Anne-Marie, you won't be surprised to hear that I agree so very much with what you're saying. And I think that, you know, the idea of nurses having agency is critically important. And I sometimes get the feeling that nurses are almost overlooked as, you know, players in the health market. And I'm going to talk a little bit more about that when I get to my bit to be able to talk. But I think that it's, in many ways, it's not rocket science, is it? You know, if people don't want to work in a place which is horrible and where they're badly treated, and why we cannot grasp this, I do not know. And the second thing I think we're not grasping is that nursing is a best buy in health, without a doubt. All the studies show that if you employ a nurse, you get a good bang for your buck. And yet, you know, we should have this on big billboards everywhere, employ a nurse. If you look at the COVID pandemic, we were everywhere in the entire care pathway, from testing to intensive care, to palliative care, rehabilitation, everywhere, education for prevention. And you would think that that would translate into a message that said, no nurses, no health systems. But somehow it doesn't seem to. And I think that's something that, you know, I'd be really interested to hear everybody's ideas on. Why not?
Thank you, Dr. Barbara. Over to you, Professor Helen.
Okay, thank you, Anne-Marie and Barbara. So you both mentioned social structures and agency, and I, as a sociologically minded nurse researcher, I suppose those are the tensions, aren't they, between structure and agency, and how we negotiate those as individuals, both and as a profession. So I've evaluated some projects which in London, they're mostly based in London. One, although one was national, one was a Compassion in Practice initiative, which was a response by nursing as a profession to deal with issues, in my view, which scandals, in my view, which were caused by underinvestment by government and by poor management. The second was a project in London, which was the Capital Nurse Preceptorship project, which was about addressing retention and recruitment in London. And the third, which I'm doing at the moment, which is a response to COVID and the retention problems we've got in London and the severe demoralisation we've got amongst nurses, is a an initiative which is introducing nurses to system working. And I think system working is a way to think about how, as an individual, where you do have agency, but it may be constrained by social structures, it's a possibility to think, well, how can I work my way through the system? How can I network? How can I form relationships across systems which enable me to get where I want to get in terms of professional efficacy? And I think from evaluating those 3 projects, what I've drawn out in papers are the potential of nurses' individual agency, the potential of compassionate leadership, and the potential of systems working. And I personally, I think it's more than incentives or pay or those social structures that are important. It's about feeling valued. And I think nurses don't feel valued. And that's particularly strongly felt now after the pandemic, where nurses, as Barbara says, were there and suddenly we're not going to pay for nurses. And it's about, as Arlie Hochschild and Pam Smith said a long time ago, it's about recognising the emotional labour that nurses do, and people need to be paid for it, basically. Thank you.
Thank you very much for all your answers to our first question this evening. I'll move on because of time to question number 2. What are the priority areas for a global health nursing workforce? We know that there is currently a lot of activities on the role design, burnout, factors of retention, impact of registered nurse-patient ratio. How can these and other factors help us to see nursing as a global resource with a stronger global presence and image? I'll first give the floor to Dr. Barbara, to be followed by Anne-Marie and Helen, please. Thank you.
Thanks, Dr. Amelia. Great question. So, priority areas for global nursing workforce. I have been thinking about this question based a lot on my experience with Nursing Now, which eventually got into 126 countries. So it was an amazing experience to be talking with nurses from all of those different countries. And of course, what is clear, and I think important to remember, is that all countries are different, and they all bring something different to the pot, to the melting pot that is global nursing. And we can learn from each other, and this became very clear too. So it's very important to remember, and this was the sort of value of Nursing Now, I think, a value upon which we based the entire campaign. Everybody has something to teach, and everybody has something to learn. And that's very important to me to always remember. So I sort of start my answer with that, really, as a preamble. I'm coming at this from somebody with a lot of experience, but not everybody will have other ideas. We talked a lot about retention in the previous question, and some of the factors that influence that, and they of course are critically important. When you look at nursing as a global profession, so in other words, if you look across the nursing profession globally, which Dr. Amelia does in her job, one of the things that is very obvious is that 90% of nurses are women. And I think when we start to look at things like voice and agency and influence and the way workplaces are designed, it's very important to remember this fact. And in Nursing Now, we did a global survey along with an American organization that I'd worked with before, where there's a woman who's a sort of global expert on looking at issues to do with gender and workforce. And what we found was that many nurses who were women reported still feeling unsure about speaking in a public meeting. And that was interesting to us because we wanted also to look at leadership, because leadership is one of the strategies that is, as indeed it's in the State of the World, the strategic directions on nursing and midwifery. It's one of the pillars to actually move nursing, you know, so something in leadership is seen to be able to lead to change. And that's what interested us in the Nursing Now campaign, coupled with this finding, which was very powerful, that women nurses reported this, you know, that they weren't confident at bringing arguments to the table. So we wanted to look at this, and when we did the evaluation of Nursing Now, here's something that that we looked at because we started to look at power and nursing, and this was very a fascinating area. What we found was that nurses are very good at telling their story, the power of the nursing narrative. They have wonderful stories to share. We have so many of them, which we had for the Nursing Now evaluation, which we have published in our report, many of them. When they tell their stories together in 126 countries, what then happens is that there's the power of us, not the power of one, the power of us. And what we believe happened with Nursing Now was that it became a global social movement, which of course was enabled by being mostly online, which was necessary because we had a pandemic going on during the Nursing Now campaign. So you might wonder, would the same thing have happened had we not been online? But we were, and I think together we became powerful. And we actually took some practical skills. We learned to be great advocates. So we learned to do our elevator pitch, to tell our story, to back it up with data, and to find friends in the media, to make friends with the media so that we could tell our story to a big audience. So I would say globally, we have common stories, common threads, and what we can do globally is to build the power of us through telling our common stories. Thank you, Dr. Amelia.
Brilliant. Helen, did you want to share something on that question?
Yeah, thank you, Barbara. So this question for me prompted me to think about how far we have to go in developing a secure sense of self as nurses, as Barbara, I think, was saying. And I've seen this throughout my career. It's not only nurses as individuals, but nursing as a profession. And I've done, I could give you an example of someone when I was at Surrey who completed her doctorate as an advanced practitioner, nurse practitioner. When she went to have a new sign put on her door, Dr. So-and-so, she was told by the medical consultants to take it down. So it's not just individuals, it's structures as well that basically do us down, that eat away at self-confidence. And there's also a lack of awareness, I think, amongst ourselves about how a lack of self-confidence shapes our practices. I was talking to someone today who was an ex-PhD student. She's now, a doctorate and a skilled psychotherapist. And yet she was saying she'd been invited to teach on psychotherapy training program, and she felt she didn't have the skills to do it. And we talked about imposter syndrome, because I think that's, again, very common in the students I meet. And here, when I'm talking about students, I'm talking about postgraduate students. So these are the students I teach at postgraduate level are skilled senior people, and yet they're still coming to me with problems with self-confidence and a reluctance to analyze why they feel like that. And I don't mean go into in-depth psychological, internal psychological investigations, but to think about how the social structures are encouraging them to doubt themselves. And I would say that goes also for considering how white nursing is and what privileges this gives white nurses. And I'm conscious, and having seen the chat, that we have a panel that are all white. So there are some deeply ingrained issues we have to think about in nursing. So I think that's what I wanted to say in response to that question.
Thank you, Helen. And did you want to contribute to that question, or we'll move on to the next one?
Well, maybe just very briefly, I think understanding, and Barbara mentioned power, and, there's different sides, and there's positive and negative, how power may be used against you, but also how you can use power to your advantage. And, partly the Harkness Fellowship that I referred to before, that was actually looking at how American nurses had managed to influence in the Clinton, it shows you how long ago it was, health reform effort in the US, and the tactics they used. And, what the ANA and others were doing was providing courses in political leadership for nurses there. Now, I think we all need a solid bolus dose of political leadership training. And I think, it's education, leadership, investment, and building that capacity and self-belief, I think, is something that will emerge from that. But also understanding how political systems themselves operate and can be influenced. That will give agency. And of course, as Barbara's already said, equally, the media is a big player in this. And debate, it's not simple, but debating skills, marshalling an argument, critiquing, these are all things that we try to inculcate in our students. But actually, or making a pitch as an entrepreneur, these are core skills that we provide at university. And I think just get practice, do it with your friends. And, I think nursing now is an amazing kind of experiential experiment. And I think Barbara's point, would it have happened the same way had we not been online? I don't think so, because it takes all that extra effort. I think whatever it is in nursing now, we need to bottle it. But I believe building a solid platform of training and leadership in particularly policy development, design, and political leadership in particular. Look at what we've seen with, industrial action and different forms of protest. We can do it when we put our mind to do it, definitely, and move mountains in doing so.
Wow, excellent. Thank you for all your answers to that question. I will just move on to question number 3. For nurses who see opportunities to work in other countries, how can we ensure that they are supported in their new settings? How do we encourage them to take up leadership positions? And how do we tackle racism and bullying, which are often reported by nurses who do migrate? I'll give the floor first to Professor Helen, please.
Thanks, Amelia. I'll start with the words of Carol Baxter. I went back to her work today when I was preparing for this, who sees that there are benefits to international migration. Individuals can benefit through broadening their professional experience, and their personal and social skills can be enhanced through working in different and challenging environments. As Anne-Marie has suggested, employers benefit because of a broadened labour market, and patients can benefit through receiving more culturally sensitive care. However, as I've already suggested, my research shows that there are some serious downsides, and bullying and racism are some of those. And internationally, there are some downsides. So there's the knowledge and skills drain, and there's the emotional labour of migration. I think Ali Hochschild and Erin Wright's work is really useful there to show how those women who do migrate bear the burden of family relationships and missing those family relationships, and who knows what damage it does to children not to have their mothers there. So the 3 studies I highlighted at the beginning in my introduction outlined how entrenched racism is in the NHS. And I think over the course of this research, I've recognised how difficult it is for trusts and individuals, you know, chief nurses in trusts, to recognise racism within their own trusts. It's not something we want to acknowledge. And I've had literally a chief nurse, in response to a report that she's read of my research, saying she's going to report me to the NMC because, you know, she thinks I've you know, I'm making things up. I'm lying, basically. I mean, so I think it just shows how emotionally embedded these defences are. But despite the number of ONs in the NHS, particularly in London, and their success in achieving promotion, which was a very different position now to where we were in 2008, which was the Rio study, I still hear stories of racism in nursing and the NHS. So at a recent study day at UCLH, it was a room of 80 nurses. I would say at least 30%, 40% were from overseas. And yet people were very reluctant to talk about racism and how we should tackle it. I think it's very, very difficult to talk about this openly, both amongst white people, but also amongst overseas nurses themselves who are from Black and minoritized ethnic backgrounds. So there was lots of acknowledgement in the room that there was a problem, but people found it very difficult to address. Personally, at that study day, I listened to the first nurse specialist in a particular field. Amazing woman, had done, you know, incredible innovatory practice, and she was an overseas nurse. She had experience of both patriarchy and racism, and she gave the example of arriving at a clinical meeting abroad, and she was asked, "Have you got the refreshments?" So that stuff, that basic stuff, still goes on. And there is plenty of evidence in the literature that nurses who undertake new work roles tend to be undermined in the face of medical challenge. There is institutional racism, but there's also entrenched patriarchy as well. I recently supervised PhD Dr. Monday Ugiabi in his doctoral studies. He explored the integration of Nigerian nurses into the British health system. And his participants, who were senior nurses in the NHS, Band 8 and above, had experienced racism. But again, they found it difficult to talk about the racism they'd experienced. They succeeded, but they didn't want to talk about the racism. And another example is a PhD study into Black nursing academics in the UK who also faced racism and yet also found it difficult to talk about the racism. So it's challenging, pervasive, and of course is denied by a large proportion of people who don't share the experience and yet who have power in the NHS's snowy white peaks, as Klein talks about. So at the moment, I think we've got the position where overseas nurses are taking up leadership positions, but middle management positions are filled by overseas nurses and Black and minoritized ethnic nurses, but senior roles aren't. And there's a reluctance systemically to discuss racism and acknowledge white privilege. So how you tackle racism and bullying, I think it has to be at both structural level and at individual level, and people need support to do so. Thank you.
Thank you, Professor Helen. I'll give it to Professor Anne-Marie. And
yes, thank you, Dr. Amelia. you know, concur with what Helen was saying. But I mean, I've got a PhD student who's looking at the experience of overseas nurses coming in. I mean, there's obviously a lot of endemic racism, and, you know, those in the staff survey, those metrics are stubbornly immovable, it seems, despite increasing awareness. But I think there are efforts by, certainly in the UK, NHS trusts in particular, and of course there's an even larger employment sector in social care. You know, that workforce is bigger than the NHS itself, and then there's private healthcare as well. But to welcome people, make them feel, you know, at home, offering and extending hospitality. And I think there's a lot of trusts are working really hard at that and providing, you know, stopgap of accommodation and various kinds of incentives, and designing programs with people who nurses who are coming to work here and being alert to how they are trying to value them in a very tangible kinds of ways. So I think slowly things are translating into that kind of improvement practice in the work environment. But there was just another point I wanted to make in relation to speaking up, and I don't underestimate the difficulties and how difficult it must be. But some of these nurses, and I had another PhD student who was looking at Portuguese nurses, Claudia Leone, and we published a number of papers on this topic. They are incredibly enterprising at setting up their own networks and helping each other, you know, to adjust, to adapt, and also to find a place within the system and navigate the system. And there are different, you know, online groups, everything from where to get, you know, food that reminds you of home, deal with, there's a special Portuguese word for it, I can't remember it, but it is about homesickness and that sense of nostalgia. So there's a lot of self-help groups, and people are really innovative in their practices. In, you know, it's all happening below the radar and informally by those communities themselves. So I think there's a lot that's being done in a positive way to actually help people flourish and succeed in the system as well. But one final point I just wanted to make on this speaking up, because I think that, you know, nurses who are coming into the system feel even more reluctant, because I think, keep my head down, you know, don't want to cause trouble, etc. Otherwise I might have my visa threatened or something, you know, there's that hanging over them. Is a lot of nurses in different countries, and Amelia, you'll know more about this than anyone, but they're actually classed as civil servants. A number of African countries, and I know a number of European countries, which means you're part of the state. So that is almost like putting the handcuffs on you. So I think that's something that we don't really acknowledge. And yet, you know, you don't have the benefits of being a civil servant in government terms, of participating in that decision making. So it's a curious kind of liminal status that some nurses have, where they are part of the state but not part of the state decision making process. I think it's a really interesting topic, but there we are. That's my 2 penneth worth. Thank you.
Thank you, Professor. And over to you, Dr. Barbara.
Just 2 quick things, couple of quick things to add. One is that I found in my work on health workforce migration at WHO is it is very easy to begin to think about migration in terms of numbers and not in terms of people. You know, how many are coming, where are they from, where are they then going? It's all very exciting economics, but it doesn't reflect the experience of people. And I think one of the most powerful things I ever did at WHO was that excuse me, I asked a migrant nurse, a nurse from Kenya, to come and speak to the committee in WHO that was talking about migration. Well, they were speechless because here was a person with a story about, you know, her journey, how she was treated, her family back home, the hospital she left, the hospital she went to. So remember that each of those people that's joining your workforce is a person. And the second thing is that I think is critically important. It starts with me. It starts with me. I have to recognize my own biases, what I'm doing, what I'm saying. It starts with me. I may think I'm the most wonderful person, but you know, I have to be willing to start with looking at myself and speaking up, even if it's difficult. Sorry, coughing to death here, but I'm still.
Wonderful. You know, I am just amazed with all the answers and everything that you have shared this evening. I would like to ask the last question because we have time and we only have one question from the audience. And if you would like to contribute to, there has been a lot of information on the rapid evolution of artificial intelligence. What role can AI play globally in addressing the international workforce shortage and in helping to address burnout? Maybe just one line from each of you, please.
Well, I'll go first then.
Okay, thank you.
Well, AI is already being used, isn't it, in migration? It's being used. The World Economic Forum says increasing use of AI in migration with growing mobility and inequality sets to exacerbate the digital divide between and within states regarding migration and mobility systems. So it's being used for passport recognition, it's being used for processing applications, and I think myself it'll lead to further racism, actually. But that's pretty negative. But I think we have to be very careful about what these systems are going to mean for migration.
Thank you, Professor Helen. Professor Anne-Marie?
Well, I'm going to be a bit more mundane in the sense that, you know, and contrarian perhaps, and arguing for AI with caveats, of course. But, you know, I think it can help to, everyone sees it as a bit of a magic bullet, and I'm sure that's much too simplistic. But in dealing with some of the pesky bureaucratic annoying things that we have to do that actually could be done more effectively and efficiently by AI, rather than, you know, nurses are one of the major issues that's raised about burnout is the amount of paperwork. Now, how can AI help to deal with the volume of paperwork that nurses actually have to do? There's got to be AI as part of that solution, but that needs, this is one of my gripes, that needs nurses to be building and developing those software solutions, or however it works, talking to the AI people who are running these systems and actually there at the point of design of these systems, and not just seen as a kind of, you know, recipient of their some phantasmagoric delivery, you know, that someone else, software engineers, have designed for us. No, we need to be there at the table. Otherwise, we're on the menu, as they say.
So I have an idea. And my idea is this. What about if, when nurses qualified globally, we had some pre-conversations about education, competency, what we expected. Everybody had their competency measured when they qualified. And then it could be put onto a card, like a credit card. And wherever you went in the world, they could swipe the card and immediately you'd be able to see what you were competent to do as a nurse, wherever you were working. So it would include everything about languages, competence in clinical practice, the whole lot. And though it would be difficult, I do not think it's impossible. I'll be dead probably when it's done, but mark my words, that's where we're heading.
I'll just
Thank
come in
you.
there quickly, Barbara.
Mhm.
Capital Nurse introduced passports for nurses across London, and that was the very reason they did it. It was to allow nurses to move and have more choice in where they wanted to go and work and pursue their careers.
Thank you very much. We only have 2 questions from the audience and just quick answers on how can we attract UK residents into nursing. Just 1 or 2 points from each of our panelists, please.
I don't mind going first again.
Yes, please.
I've got a daughter who's just started as a care assistant in a mental health trust, and she's loving it. And she wants to train, which is brilliant. And I've been so impressed by the management she's experienced. However, the NHS offers seemingly a really good career structure, but she's met with continual setbacks through the IT and with people being so busy that they don't phone her back, or they don't respond to emails. And I think there's an aspiration to really make the NHS a learning organisation to offer really meaningful career pathways, but it's probably not achievable with the current investment strategy that we have from the government.
Thank you, Helen. Anne and Barbara?
Shall I go next, Barbara?
Yeah, you go.
Yeah, I think, I mean, we have to be very sensitive to generational shifts and differences. And, you know, I would like to have a 2-pronged attack at this. I think we need a new model of leadership, intergenerational leadership. Barbara, you know, talked about learning and that being a kind of constant sort of process. And, you know, I think that because we're seeing a kind of hollowing out of more experienced nurses leaving, and, you know, rapid turnover from nurses who are relatively junior in terms of their longevity, I think we've got to really get laser beam focused on how do we keep those, you know, newly minted nurses, as it were, look after them, shepherd them through, and also use that seasoned experience to great advantage. I think we can combine the two and develop, you know, a form of intergenerational leadership. That's my fantasy.
And I think we have to address the image of nursing that many people hold, I think. I Googled, for a talk I was doing, I Googled images of nursing, just put that into Google, something like 17 million hits. And they were all either angels or sex pots. They were all white. They had funny little hats on. It was so upsetting. And I thought, goodness, if this is what people think about nursing, I mean, the point of this is not that it's real, but it's what Google thinks about nursing. So that's critical. That's what people think about nursing. So I believe that we really do need a good ad campaign. We need to take some professional folks in and say to them, look, change our image of nursing. This is what you do if you're a big firm with something to sell. We want to sell nursing. Why are we not doing it?
Thank you very much to all of your answers to that question. We have only 2 more questions. How do we promote nursing in social care as a good place to work, as nurses in this area get a lot of negative press? Over to our panelists, please. Helen?
Yes, but there's lots to celebrate, isn't there? And I think it's partly related to Barbara's point about image. People don't know what nurses do. And that's often obvious when you interview people coming to train into a nursing preparation program. Not all of them know what nurses do. So we've got to change both the image, but also knowledge in society about what nurses do. Yeah.
Anne and Barbara?
Well, just building on that point, and the range of roles, you know, in the kind of everything from dealing with, you know, critical care, outreach, homelessness, the justice system. There's a huge range of roles that people are unaware of, and it's not just the what, it's also the how, you know, what the skills that you need. I mean, that's getting back to Barbara's point on storytelling. I think that's one of the most powerful vehicles. I mean, there's good media, you know, examples that we can use, and you know, I'm sure a really smart campaign based on some of the most successful campaigns. I mean, we did try to do this when we had the Prime Minister's Commission on the Future of Nursing and Midwifery under Gordon Brown's administration. And unfortunately, putting it into practice wasn't possible because, you know, we had a change of government. But I think something that's very bold, imaginative, and has to be co-designed by, I would get, you know, young nurses to actually create the image that they excites them, because they're the future. Maybe not so much people of our generation.
Yes, I shall say nothing about that, Anne-Marie. But of course, you're right. It needs co-designing, and you know, the nurses coming in now are the people who need to be doing it, because they're the people who will leave within 5 years, and we know that from research in young people. The people who go into nursing are not from Mars; they're actually young people from our planet. So they're going to behave like all the other young people that McKinsey surveyed, and they're going to be on their way after 5 years. So, you know, I think in general, we need to look at that. We also need to work on what, if you talk about social care, what comes into people's minds, you know, into the general population minds. It's kind of making toast, isn't it? And, you know, talking to people and doing a bit of shopping and that. So we need to educate the public as well as to what nursing and social care is actually about, and nurses themselves. So, you know, when a nurse is going in to visit a patient, they can look at that and this goes back to AI, I think. I'm very fascinated by that, because in systems work, Helen, I'm sure you know, because you mentioned it, you know, they have simple, complicated and complex problems. And complicated problems are problems that can be delegated step by step. So they can be delegated to a robot. So of course you can get a robot to put somebody in the bath and lift them out and make sure they're dry and all that kind of stuff. But what you can't do is complex care as a robot, because complex care is something like bringing up a child. And, you know, you may have 3 children, but they're all different. And the way you bring them up is not a playbook. It's responding to each one. And so it is with social care. You know, you can say, yes, we can do all these things, but what you do depends on the person, how they look, what their mood is, whether they're crying, whether their family's there, all of that. And that's hugely complex, fascinating work, incredibly interesting, and hardly anybody knows about it.
Thank you very much. Our last question in just 30 seconds each. How can we encourage everyone to feel safe to speak up? Helen first, please.
By having education and awareness training, by supporting people as we found with whistleblowing, it's incredibly difficult, and people shouldn't suffer for whistleblowing. I actually worked with the doctor who blew the whistle on the down in Bristol before he went down there, and his life was destroyed. So, you know, people suffer when they speak up, and the risks shouldn't be diminished at all.
Thank you, Anne.
Induction's a very important part of socializing people into new roles and jobs, and I think it should be part of an induction process, and every workplace should make it one of the first things that they say to people, and it should be mentioned on a very regular basis. This is the expectation. It's your professional duty to raise issues. If you're there in a managerial leadership position, I think you need to support people to stiffen their sinews and call it out. And you can practice that as well, in your work setting, and also gain help to articulate and actually do it. But I think an open and so-called just culture will help a lot in that matter.
And I think to add to what my colleagues have said, I think also that, media training is critical, not only to work with the media, but to understand how to frame an argument, how to stand up, how to make it. We should be demanding that as a profession. We shouldn't be hiding behind the camera, not sure what to say. We should be able to bring our argument and express it and say it. And I think those leadership programs where they have an actor come and teach you how to act are very powerful and very important. But I would say also get a mentor and a coach, as Anne-Marie said, get support, get help.
Thank you very much. We are now coming to the closing, and we have about 1 minute each to our distinguished panelists. And I'll give the floor to all of you for your thinking around what is the most important thing for us all to be aware of when thinking about the nursing workforce on a global stage.
I'm going to butt in here. I think it's advocacy. I think it's influencing at every opportunity. Nursing needs to be at the table with all the major international meetings, WHO, World, not just the World Assembly, World Economic Forum. I'm sure there's many more that I can't reel off at the moment, but I think, growing that influence. And I'd love to see a super network of international organizations, of the current nursing organizations, building a coalition where they could field people to these meetings and develop training programs so that the articulacy of that advocacy, as Barbara's mentioned there, is just part and parcel of what nurses do every day.
I would say, in fact, very similar to Anne-Marie, I think my message would be politically savvy. Learn to be politically savvy. Learn to build those policy bridges. So go beyond what we say in nursing to think about how do I frame this as an argument that a politician's going to be interested in, that's going to catch the public eye. So a colleague of mine, Alison Leary, has done some wonderful research on looking at big data, and she's looked at big data about those people, a cohort of 23,000 people who had lung cancer, and she looked at the progress of their disease and who looked after them. And what she found, one of the things she found was that those people allocated a nurse at diagnosis lived longer. Imagine if that got out into the public domain, everybody would be demanding a nurse. and why aren't they? So, you know, we need to be strategic about that. We need to be inviting the Prime Minister along to listen to this argument. How many of you who live in the UK have invited Keir Starmer out to work with you, you know, as a nurse, to see what nurses do? This is how we should be thinking. So that's my message.
I suppose my message would be work with other nurses and work with other allies so that we can achieve what both Barbara and Anne-Marie have set out.
Thank you very much to our distinguished pioneers and our panelists this evening, Professor Dame Anne-Marie Rafferty, CBE, Dr. Barbara Stilwell, and Professor Helen Allan. A huge thank you to everyone for your time and for coming in and listening and contributing. Thank you, of course, to our pioneers for your talents, your leadership, your vision, your passion, and your perseverance, and everything that you have shared this evening. Thanks to those who have helped to plan and organize this evening's presentation, including the Royal College of Nursing Library and Archive team, and the fellows representatives who have given their time. Before you leave, please fill out the evaluation form. And I wish you all the best in 2024 and beyond. And I hope that we will continue to work together, continue the conversation, the dialogue, the collaboration, so that together we can work and better understand global forces impacting nursing workforce, and of course, drive with our vision, passion, and perseverance to ensure health for all and health for everyone, everywhere. Have a lovely and restful evening. Goodbye.
Thank you.